And thank you very much for joining.
Yeah, it's a...
So, Mark, can you just give us a quick brief on the case that you have?
Yes, first of all, good morning, everyone. Welcome to Granollers. Let me introduce my team today. We have Dr. Pomares, Dr. Laviladric as anesthesiologist, Sandra, and as a nurse, and Cristina as well, Dr. Arcediano as my assistant, and Dr. Ruiz, who is ready to present, to introduce the clinical case today. Can you see the screen, the PowerPoint?
Yes, we can see the slides, yeah.
Do you hear me?
Yeah.
Can you hear my assistant?
Do you hear me?
Yes,
Hello?
loud and clear.
Yes?
Okay,
Good
perfect.
morning from Hospital de Granollers in Barcelona. This morning case is a 78-year-old female with allergy to penicillin and the common vascular risk factors. This lady has a right lower limb ischemia, Rutherford 5, with present femoral pulse, with absence of popliteal and distal pulses, with 3 weeks rest pain and a small interdigital ulcer. In the duplex ultrasound study, we have patent deep and common femoral arteries with an 10 centimeters occlusion of the superficial femoral artery almost from the beginning, with a stenosis in the P2 level and also disease in the BTK segment. Our treatment approach for this case will be left femoral access with a crossover technique to treat the right fempop lesions with mimetic stents and non-compliant balloons, and maybe also in these balloons for the BTK level.
Okay?
Okay, yep.
Perfect. So we'll be in live. We perform a crossover approach. I am going to show you the first angio. Can you see the screen?
Yes.
Yeah? Yeah, perfect. So this is the first angio. As echography show us, is a occlusion of the SFA with 3-4 centimeters. At the beginning is patent. So this is the recanalization at P1, at the beginning P1 in Hunter canal. Good outflow, good diameter in the popliteal area. This is the P1, P2, P3. It's patent, maybe with high-grade stenosis in P1 at level of patella, detected by ultrasound. Maybe in the angio it seems mild, but for echo is a high-grade stenosis. As outflow at the below the knee vessels, we have anterior tibial artery as a main vessel, as you can see here. But at the middle part, maybe it's quite diseased, maybe occluded. And on foot, so it's already for class 5, so we need to treat. This is the anterior tibial distally. So we'll see. We try to recanalize the SFA using a Navicross catheter of 35 and command 18. So just win life. Do you have any questions, any comments?
Just the angio that you did below the knee there, so you have the AT. Was there a blush as well from the PT, or is that just an artifact that we're seeing here?
So we'll see. It's the angio is a little bit contrast from the common femoral artery. So I cannot identify a good vessel on foot. Maybe in the pedal artery is patent. So we try to recanalize the anterior tibial artery, and then we perform ultraselective angio on the foot.
Yeah, fair enough.
Yeah,
okay.
Yeah. So this is the 018 gut wire. It's quite easy. Maybe it's too easy. I don't like it. So we'll see. The clinical is not acute, neither subacute, but we can cross very, very easy, as you can see. I'm sorry for that, but I think we are in the true lumen. So, copilot, sisplau. We are trying to see if we are in the true lumen, but I think so. What do you think?
You can actually feel it tactile.
Yeah, it's perfect. It's quite easy. It's so easy. Maybe at the beginning it was tough, but not during the navigation. Yeah, it's perfect. Yeah. Retirem el torque i donem la copilot. Yeah, I think so. So we are going to perform angio to check if we are in the true lumen, of course, and then we advance the catheter to go to the below the knee vessels. How would you treat these kind of lesions? The audience, the panelists? Any comments? Not yet?
Hi, Marc. It's Fernando Gallardo. How are you doing?
Hi, Fernando. How are you? Fine.
So
And
do
you?
you think it's like a fresh thrombus lesion because you cross it really fast?
Yeah.
Or if
Yeah,
it is,
it's too
you will
easy,
change your
yeah.
algorithm, I suppose.
Yeah. Yeah, I don't know exactly. So the clinic, the symptoms, it's not acute, neither subacute. It's a chronical symptoms, but it's true that the crossing was too easy. So we'll see. We'll see. So in these cases, maybe sometimes, so well, not sometimes, as usual, I perform a mechanical atherothrombectomy to try to remove as much thrombus of fresh material or fragmentable material as possible before placing the definitive treatment. So we'll see. We'll see. I think so. Maybe it would be my option. So maybe I change, at least at the beginning, the vessel prep. I will change that. Yes.
Yeah, that's the question. With your experience, you have experience of massive distal embolization if you just do POVA or vessel prep with any score recruiting balloon?
Yeah, it's true that the scoring balloon. I don't use anymore POVA for vessel prep. You know perfectly well, but I use a scoring balloon, and I think that the embolization is reduced if you use in this kind of situations. So it would be a possibility to use a scoring balloon to prepare, but I think. I have a 6 French sheath, so it's that I could use a Rotarex 6 French, but the artery is more than 5 millimeters, so I would need 8 French, I think. So I can change the sheath or using another kind of devices like yeah. I need anyway. I need to change the sheath if I use any atherectomy device. So we'll see. We advance the sheath, the white wire and the catheter go to the below the knee vessels, Turkey, to recanalize the anterior tibial artery. And then, while I am thinking about the treatment.
So while you're trying to cannulate the AT there, probably just a quick question for the previous speaker here, for Maria.
Deixa'm performar la guia.
Yeah, Maria, you mentioned the first case where you put in the superior stent and you've got to follow up for about a month. Would something like a shockwave would have prevented you from putting in that superior? Obviously, there are cases where bailout stents are going to happen regardless.
Deixa'm performar, fica el
would
tap,
this
tu.
have been an option?
Deixa'm performar. Oh, doncs. No.
Not a big fan of stenting, so now I use very often a shockwave instead of stenting.
Okay, thank you. So,
Deixa'm l'introductor de guia.
Mark, probably while you're attempting to cannulate there, we might just go ahead with one more presentation here and then come back to you.
Yeah, perfect. Thank you. Whenever you want.
Thank you. So, yeah.
Can I just make a comment to Maria? Maria, please.
It's using a non-compliant balloon, jade balloon 3 by 150. Espera't, no? So to treat this area, so a 12. This is the outflow in the foot. Just a moment. This is a selective angio through the navicular catheter in P3. And this is the outflow ultraselective angiography through the balloon once we recanalize the occlusion in the middle part of the anterior tibial artery. It's not the best outflow, of course, but the Rutherford 5 in this patient is a small ulcer. So we have different segments, especially total occlusion in the SFA and the stenosis, high-grade stenosis in P2. So I consider that if we are able to treat well the SFA, anterior tibial artery, and P1, due to the small ulcer in her foot, I think it will be enough. What do you think about that?
So the ulcers you mentioned are second and third digit, are they?
Yes, it's a very, very small, superficial. It's not contacting the deep tissues, non-infected. Okay. So this patient for me, it's more rest pain, rather for 3 than 4, because it's a very, very small ulcer. Maybe tomorrow or maybe in my presentation on Saturday, I can show you the ulcer because it's very, very small and superficial.
Okay. So I think probably I'd agree that because of the small size of the ulcer, treating the proximal lesions might give you a better outcome or a better image even of the arch. So probably might be worth seeing what the arch looks like after you've treated proximally and then take it from there.
Yeah, fully agree.
Okay. So
and then we as usual, we can, if the ulcer is not healed in 2 weeks, we can perform a second look. But I am sure that is very, very. So the ulcer will heal in a few days.
Okay, Fernando,
Vale, desinfla.
Okay, so which one are you starting with first? Are you going to go?
Yeah, now I am check the result here, but we are exchange the sheath for 8 French sheath, and then we are going to perform mechanical thrombectomy using Rotarex device to try removing as much fragmentable material as possible in the FemPop area, and then after this vessel prep, we'll see the definitive treatment.
Okay, So you're going to start with the thrombectomy at the moment.
Yeah,
Yeah.
thrombectomy, yes.
Okay.
Okay, retirem. So we have to exchange the sheath. So if you want, I can notice you again when we are starting
Okay.
the thrombectomy.
That's fine. So we'll move to Professor Mossad Siliman's presentation for the time being on distal embolization, which is actually quite timely with this particular part of the procedure. So Professor Mossad Siliman on distal embolization is a serious issue during debulking in vessel preparation.
So to place the guide wire from Rotarex, and then we are going to start the Rotarex. So retirem aquesta guia. Espera un momento. So I'm not ready yet, but maybe in a few minutes.
Okay, so we can leave you and come back again, but just a quick question, as we were discussing the distal embolization protection, seeing that this was a soft lesion and it's mainly a single vessel runoff, would you, are you a believer in distal embolization or not?
Depend on the device you are using. So the Rotarex, in my experience, I don't have any embolization while I use the Rotarex if you perform correctly the Rotarex. So I had some embolizations using Rotarex, not using Rotarex, but also after a dilatation. So yeah, this is important. So if I use a jet stream, for instance, in this case, I would use filter. In my experience, Rotarex 8F has high powerful capacity of aspiration, of suction. So in my case, in this case, I won't use the filter because I will use Rotarex.
Yeah, fair enough. Okay, so we'll leave you to it, and we're going to continue here and come back after the next talk.
Oh, okay, thank you.
Yeah. So our next talk is by Ahmad Sar on orbital atherectomy, approach for effective vessel preparation. Yeah.
So this is the last passage of Rotarex. So it's the third. So I am removing the distal cap because I use the distal cap as natural filter. So I always perform thrombectomy, mechanical thrombectomy, and the first part leaving 2 centimeters as a natural filter. Then I check if the proximal part is quite clean. So I am going to show you the angels. Once I check the proximal part is quite clean, I am going to remove the distal part, the natural filter. So I just doing that. So I just in 1 minute I remove this device and check again the angel to decide the treatment at that area. So I am removing the Rotarex. Rotarex is working to take advantage of during the requirement. So I think I am going to show you the angels, but I think it's the material, the fragmentary material is removed 80-90%, as you can see in a few minutes. Okay, para? Retiro?
Yep.
Vale, necessitaré 5 i 5, ho faré des de dalt. Ojo aquí, Vale, quito. keeping the natural filter so the embolization issues are quite zero. So this, I am going to show you the selective angio's before removing the cap. So this is the proximal part before this third passage. This is the middle part. And this is the distal part. Do you think about that, Anju?
Yeah, so I'm probably not seeing it properly from where I'm sitting at the moment, but is there still a distal lesion there?
Yeah, I think the problem was the distal and the proximal lesion, I think.
Yeah.
We'll see right now the angio.
Yeah.
Just a moment. And the proximal part. So this is the SMS, see?
Yeah.
The flash is quite faster, obviously, than before. Do you think?
Yeah, looks good.
Yeah.
Yeah.
What do you do the next step for you? Distal, 4-4? We still need to treat the T2 segment, but we are checking. It's good. Sing. Well, it's quite good. Maybe in anterior tibial artery we need to perform more treatment, but I think so far it's quite good. Do you agree?
Mark, this is Solomon with you. I wonder how many times you can go through with many runs of the atherectomy device, the Rotarex especially. And one more thing, do you find any, at some times, that the atheromatous or thrombotic material collected in the reservoir makes a difficulty in the aspiration system, because it so frequent happens with me when I go with 3 or more runs. And finally, do you keep looking at the distal end of the wire? Because with my juniors, they sometimes they have the wire impacted into a small vessel, and this causes some kind of bending of the wire, and this caused us an extravasation of the material and even rupture of the vessel. So do you keep some of any more of the tricks that can help us in refining our practice?
Yeah, so it's different if, I agree that it's different if you are treating acute or subacute than chronic material. So a chronic material, maybe it's more difficult to remove, more difficult to fragment, to break the material and deaspirate in the reservoir. I agree. When the key point here is for me, it's not to remove all the material, but remove the fresh material that can embolize distally when I use the definitive treatment as DCB or stenting or what else. So minimizing the embolization of Rotarex, many key points, I think. So first, to choose the right size. So if you have arteries more than 5 millimeters, between 5 and 8, it's much better to use if you have, it's possible due to the access, use the 8 French assist. Like this case, I started using a 6 French. I could to use Rotarex 6 French, but the channel you create using a small one is a small one channel. So I think this case is 8 French is the typical example. So it's the right size is important. First one. Second one is to keep the distal filter, the natural filter. Before removing the distal part, I always perform selective angio using Copilot and Navicross catheter to avoid removing the wire, to check if we have more thrombus or not. If we had more thrombus, so before removing the distal cap, I use again Rotarex. In this case, the artery is quite clean, so I remove the distal part in the third passage. So for protocol, in my protocol, I use 2 passages before removing the distal cap, then check and then remove the distal cap. And it's very important to go slowly to get time for the Rotarex suction capacity. And the wire, it's more important to keep distally 25 centimeters to avoid some stack of the wire, for instance.
Very good, thank you very much. So you've got very good outcomes so far. What are you going to use for the AT?
Sorry, and the anterior tibial artery.
No. What are you going to use for the AT at the moment? So you've got a good proximal result, but you still have an issue with the anterior tibial.
Yeah. So anterior tibial artery, I will use the non-compliant balloons, 5 minutes dilatation, and then check again. In the proximal part, in the FEMPOP segment, in the SFA, I would use maybe a scoring for P2 lesion, maybe some drugs, drug-coating balloon in that area. And I have some concerns about the definitive treatment in the SFA because there are some thrombus there or some fresh or soft tissue. So maybe I will go directly for stenting. What kind of stent? I am thinking about that. Maybe cover stent or maybe a self-expandable stent to very soft accommodation.
So something like a Viaban, like a covered.
I'm sure. Yes, to be sure that avoid any embolization, any complication. Yes.
Okay, so we'll probably leave you to work on the anterior tibial, and we just have 2 more presentations here, and we can come see the final angio at the end.
For sure.
Yeah. Thank you. So.
Thank you.
If we can invite to the podium Ale Ahmed,
vale.
What is after Basel 3?
The angio, the first angio in this part, because here you can see the angio. Yeah. So now we are treating the first part using a DCB and that area to reinforce, because it's, I think could be some lesion there, and especially I prefer to use DCB in that area in this case to protect the edge of Viaban. And then we'll see the popliteal. And the popliteal I perform a vessel prep using a scoring balloon plus DCB. And then anterior tibial artery, we will use the non-compliant balloons, 35 minutes aguanta la vía. 3-5 minutes dilatation. That is the plan, if nothing happens. Aguanta la guía.
So have you already used the DCB on the Viaban, on the proximal distal end, or you're still going to use it now?
Me? Not you, not always, but in this case, I think yes, because I guess some lesion, residual lesion in that area, to cover all the lesion.
Yeah.
Okay. Vale, pues dilata aquí. We needed a shorter balloon, but we didn't have available today. So for that reason, we use this balloon inside the Viaban. Assist. So 3 minutes. What do you think? Any comments, concerns, remarks?
Yes, Mark, thanks. It seems that the case is going to be finally okay, but we were thinking here in this kind of cases, no, drug-eluting balloon, atherectomy device, covered stents. We were talking here a few minutes ago about cost effectiveness. No, I think technologies need to improve with the years. They need to have a better price for us because it's not going to be sustainable in some of the systems, in my opinion.
Mark, did you hear that? Mark, did
Sorry?
you hear the last comment?
Yeah. Well, the last comment is, in this case, another option. So yeah, the cost-effective, of course. But I think it's important to avoid some complications to use a thrombectomy device in this case because the crossing was very easy, too easy indeed. And then in this case, when you face thrombus, many times you need to place, to be sure, Viaban. So it's expensive, but it's, I think, a good option for cover stent in FMPOP. So the question here maybe is, okay, if you want to use Viaban, because why you don't use primary? So sometimes I use, in the past, many years ago, I used it. So I placed Viaban before primary because the crossing was very, very easy. And then I had different embolizations in the below the knee vessels. So since these cases, I always use thrombectomy device. Even I use Viaban at the end. So maybe sometimes or many times I can use DCB after a mechanical thrombectomy device, but in this case it's not possible for me. Some thrombus is still there or was still there.
Yeah, Mark,
so
and
for me
I totally agree with your approach that we all should avoid use bare metal stent or drug-eluting stent in case of freeze thrombus because it's a disaster. I have done
Yeah,
it.
I think so. I think
case,
so.
And it is a disaster. You have all the thrombus protrusion in the stent, and then you finish
Yeah, I
with a
think
covered
so.
stent inside the stent. So I just want to
Yeah.
make the comment that all that we do is quite expensive now. So it needs to change with the time. If not, we are not competitive.
Yeah. No, I know, of course.
So, Mark, thank you very much. Our session is actually nearly running out of time, and we still have one more presentation to go. So, so far, the outcomes you've got look really promising. We'll leave you in peace, if that's okay, and with a big round of applause from the audience.